Imagine relying on a central nervous system
Yeah.
stimulant to manage your ADHD for years. I mean, it works, right?
Right, yeah, it's usually highly effective.
Exactly. You take your medication with your morning coffee, and the noise in your brain just quiets down.
Yes.
The invisible wall between you and your tasks disappears, and you can just function like a neurotypical person.
Just living your life.
Yeah. But then, somewhere in your 40s or 50s, you wake up, take that exact same dose, and it feels like you swallowed a sugar pill.
Oh, wow. Yes.
You are foggy, you're overwhelmed, your medication has seemingly just vanished into thin air.
Poof. Gone.
And you sit there staring at your computer screen wondering, did my brain break? Did the pharmacy give me a bad batch?
It is an incredibly disorienting experience.
Hmm,
And it's a scenario that so many women find themselves in.
it really is.
They assume they've suddenly lost the ability to cope or that,
Yeah.
their ADHD has somehow aggressively worsened overnight.
Mhm.
But in reality, the fundamental chemical environment of their brain has completely shifted right beneath them.
And that invisible shift is the entire mission of our deep dive today. We are unpacking the hidden intersection of hormones and neurochemistry.
It's a huge topic.
Huge. And we're doing it to answer one very specific, incredibly vital question. Does taking hormone replacement therapy, or HRT, alter the efficacy or clearance rates of central nervous system stimulants used to treat ADHD?
It's such an important question.
Because looking at the clinical data we've gathered, it is wild how rarely these two worlds actually talk to each other.
Oh, I mean, gynecology and psychiatry.
Yeah.
They rarely interact in a standard medical setting. It is a massive blind spot in modern medicine.
Yeah, they're like totally different silos.
Exactly. So to validate what you might be experiencing right now, listening to this, the transition into perimenopause and menopause triggers profound systemic shifts in how your brain operates.
It's not just hot flashes.
No, not at all. So our roadmap today is to explore exactly how reproductive hormones, like estrogen and progesterone, interact with dopamine.
And how that directly impacts whether your stimulant actually works.
Right. And then we'll get into the metabolic plot twist regarding how your body physically clears these drugs out of your system.
Which is fascinating.
It really is. And finally, why getting this delicate balance right isn't just about focus. It is quite literally a matter of long-term cardiovascular health.
Okay, so let's unpack this by starting at the very foundation. Because before we can even look at how HRT changes medication, we have to understand the baseline relationship between reproductive hormones and the ADHD brain.
Right, because hormones aren't just for reproduction.
Exactly. They're pulling the levers in your brain. And the pharmacological research uses a really great concept here. Think of estrogen as a volume dial for dopamine and serotonin.
I love that analogy.
Yeah, so when estrogen is high, the volume of these critical neurotransmitters is turned all the way up.
That volume dial concept is crucial.
Yeah.
Because we have to remember that an ADHD brain already features subtle structural and functional differences.
Specifically in the networks that rely on dopamine and noradrenaline, right?
Exactly. Dopamine is the fuel for executive functioning, sustained attention, and reward processing. So when you have ADHD, your baseline dopamine activity is already operating at a deficit.
You are constantly running on a half-empty tank.
You are. And here's where the biology gets super specific.
Mm.
Estrogen, specifically estradiol, doesn't just encourage whatever dopamine you have to hang out longer.
It actually does more than that.
Right. It actively influences dopamine receptor density. It essentially builds more landing pads for the dopamine to hit.
More landing pads. Okay, wow.
Yeah. And it does the same heavy lifting for serotonin. The clinical chemistry shows that estrogen upregulates serotonin synthesis by increasing the activity of something called TPH2.
Wait, okay, let's actually pause and translate TPH2.
Good idea.
Because it's one of those terms that gets thrown around in the medical literature without much context.
Yeah.
Right, TPH2 is an enzyme. Specifically, it is the rate-limiting enzyme in serotonin production.
See, I always struggle with that term, rate-limiting enzyme. What does that actually look like in practice?
Okay, think of serotonin production like a major highway during rush hour.
Okay, got it.
And TPH2 is a toll booth. It is the bottleneck. It doesn't matter how many raw materials or, cars you have waiting to get on the highway.
Oh, because the traffic can only flow as fast as that toll booth allows?
Yes, exactly. What estrogen does is essentially open up 5 more lanes at the toll booth.
Oh, wow.
Yeah, it removes the bottleneck, allowing serotonin synthesis to just surge.
That makes so much more sense. So estrogen is opening the toll booths for serotonin and building more landing pads for dopamine.
Right. But it doesn't stop there.
Really? There's more.
There is. It also inhibits monoamine oxidase, or MAO.
Okay, MAO.
Yeah, so if TPH2 is the toll booth, MAO is basically the city street sweeper, is the cleanup crew that breaks down neurotransmitters and clears them away.
Okay, so by inhibiting MAO, estrogen fires the street sweepers.
Exactly. Which ensures that dopamine and serotonin stick around in the brain much longer.
Which brings us to the downstream effect of that biology for someone with ADHD. I mean, when you enter perimenopause, your ovarian hormone production becomes erratic.
Completely unpredictable.
You have these wild fluctuations before eventually settling into a consistently low, flatline state post-menopause.
Right, and because estrogen is that volume dial,
Yeah.
and because it's holding off the street sweepers,
When your estrogen declines, your brain's dopamine activity crashes right along with it.
it just pulls the floor completely out from under you.
It really does. All those core ADHD traits that maybe you had managed to mask or, compensate for earlier in life.
The distractibility, the emotional dysregulation.
Yeah, the intense brain fog, they suddenly become magnified. And not because your ADHD got worse, but because the natural estrogen that was propping up your dopamine levels is gone.
Precisely. And this is the exact moment where women typically turn to their doctors and say, my medication stopped working.
Which brings us to what I kind of want to call the efficacy roller coaster.
Oh, that's a good name for it.
Because if estrogen controls the baseline of dopamine, what happens to stimulant medications when that baseline just disappears?
Well, a lot of patients, and honestly, a lot of psychiatrists, assume that the patient has simply developed a tolerance to their ADHD medication after years of taking it.
Right, like they just got used to the dose.
Yeah, but the pharmacology totally contradicts that. The idea of suddenly developing a pharmacological tolerance to a stable dose of stimulants after years of successful use is mostly a myth.
Wait, really? A myth?
Yeah, the data is very clear. Actual tolerance to stimulants occurs in less than 3% of cases.
Less than 3%. That is wild.
It really is. So when a woman in her 40s or 50s perceives a sudden drastic drop in medication effectiveness, we need to look at her hormones, not her tolerance.
Because of the literal mechanics of how the drugs work. Let's look at stimulants like methylphenidate or amphetamines like Adderall and Vyvanse.
Right.
The chemical makeup of these drugs is fascinating. The research notes that these amphetamines often have a specific 3-to-1 ratio of D-amphetamine to L-amphetamine.
Yes.
But why does that specific ratio matter when we are talking about hormones?
This is where we get into the difference between targeting the brain and targeting the body. Those are isomers, basically molecular mirror images of each other.
Okay.
The amphetamine acts more strictly on the central nervous system. It is what gets into the brain and targets the dopamine to give you that sharp mental focus.
Got it. And the L-amphetamine?
That affects the peripheral nervous system. It drives the physical cardiovascular side effects, like an increased heart rate or a spike in adrenaline.
Oh, wow. Okay, I see where this is going. Because these drugs work by blocking the reuptake of dopamine in the brain, increasing its availability.
Right.
But they can only amplify what is already there. So if your natural estrogen drops, there is practically no dopamine available for the amphetamine to amplify.
Exactly. The medication is turning up the microphone, but nobody is singing into it.
Oh, that is a perfect way to put it.
And that leads to a very common, very frustrating medical mistake. A patient complains her medication isn't working, so her doctor simply increases her dosage.
Oh, no. Because the estrogen is gone, the amphetamine still has no dopamine to work with in the brain.
Right. Meanwhile, that higher dose is pumping more amphetamine into her physical body.
So now she still can't focus, but her heart is racing, she is sweating, and she feels incredibly anxious.
That is exactly what happened.
That is terrifying. The doctor is unintentionally treating a brain chemistry problem by overriding her cardiovascular system.
Yeah. And we haven't even talked about the other major player in the hormonal ecosystem, progesterone.
Oh, right. Because if estrogen is the volume dial, progesterone is the heavy blanket.
That's right.
It interacts with GABA pathways, and GABA is the brain's main calming, inhibitory neurotransmitter.
Yes. And the clinical findings point out something totally counterintuitive here.
Mm-hmm.
High progesterone actually blunts the medication response.
It's an active tug of war, isn't it?
It really is. Progesterone enhances GABA transmission, which reduces neural overactivity. Now, that sounds wonderful if you are trying to treat anxiety or get to sleep.
Sure.
But in the process of sedating the brain, progesterone actively reduces dopamine receptor sensitivity. It makes the landing pads less responsive.
Wow.
So it is directly working against the stimulating effects of the ADHD medications.
Which perfectly explains why a lot of women feel their meds don't work during the luteal phase of their menstrual cycle.
Yes, exactly.
That week before their period when progesterone spikes and estrogen drops. And it explains why perimenopause, with its chaotic spikes and crashes of both hormones, feels like a sudden cliff edge for their executive function.
The primary takeaway here is that the efficacy of an ADHD stimulant is not a static, fixed trait of the drug.
Right. A 20-milligram pill does not do the exact same thing every day.
No. Its effectiveness is entirely dependent on the hormonal ecosystem of the person swallowing it.
So let's get practical for the listener who is right in the middle of this midlife medication failure. If declining hormones break the medication's effectiveness, does introducing hormone replacement therapy actually fix it?
The short answer is yes. HRT is obviously not a treatment for ADHD itself, but by stabilizing the hormonal environment, it can profoundly alter the efficacy of those central nervous system stimulants for the better.
Because their research highlights that transdermal estrogens, so patches, gels, or sprays that bypass the liver initially, can significantly boost the effectiveness of ADHD medication.
Right. It essentially restores that neurochemical foundation.
It opens the TPH2 toll booths, fires the MAO street sweepers, and builds back the dopamine landing pad so your stimulant actually has a baseline to work with again.
It returns the brain to its previously effective state. But, just as we discussed a moment ago, bringing progesterone into the HRT mix introduces a massive medical catch-22.
Oh, right, because if a woman still has her uterus, she has to take progesterone as part of her HRT.
Yes, to protect her endometrial lining from thickening due to the estrogen.
But we just established that progesterone sedates the brain and blunts dopamine sensitivity. So she is taking a hormone to protect her uterus that is actively fighting her ADHD medication. How do doctors possibly navigate that?
It is incredibly tricky, and it is why synthetic progestins are often problematic for ADHD patients.
Oh, interesting.
Synthetic progestins can heavily trigger that blunting effect, making the stimulants feel weak and causing intense fatigue. The clinical workaround is highly individualized care.
Okay, so what's the pharmacological recommendation?
They recommend using micronized, body-identical progesterone instead of synthetic progestins.
Because the body-identical version plays a little nicer with the neurotransmitter.
Exactly. I mean, yes, it interacts with the GABA pathways in a more natural, predictable way. And crucially, administering it cyclically, meaning taking it for only part of the month rather than continuously every single day, can really help.
Oh, so it helps minimize the negative cognitive drag on ADHD symptoms.
Yes. It gives the brain a break while still providing the necessary endometrial protection and the sleep support that progesterone offers.
Okay, so if we can solve the efficacy problem in the brain using transdermal estrogen and cyclical micronized progesterone, problem solve, right? We can wrap up the deep dive.
Not even close.
I knew it.
Because while HRT might fix the brain's receptor sensitivity, it accidentally throws a massive wrench into the body's physical filtration system.
And this is the metabolic plot twist.
Yes.
We know HRT alters efficacy, but does it alter the clearance rate? Meaning how fast the body physically breaks down and removes the stimulant.
Right.
Normally, you take your stimulant and the body clears it out on a very predictable schedule. Immediate release amphetamines peak in your blood at about 3 hours, and extended release peak at around 7 hours.
That's the baseline expectation.
But introducing systemic hormones absolutely changes how that clearance system operates.
It really does, and this is a critical safety issue. The clearance of these medications is primarily handled by two completely different systems: hepatic, which is your liver metabolism, and renal, which is your kidney elimination.
Let's start with the liver, because the chemistry here totally blew my mind.
It's wild.
The liver uses a specific enzyme called CYP2D6 to oxidize and break down amphetamines. But the research explicitly states that excess estrogen can affect these exact liver enzymes. How does that actually work? Do they fight each other?
It is a process called competitive inhibition. Think of the CYP2D6 enzymes as a limited number of taxis waiting in a rainstorm.
Oh, I love this. Okay.
Both the estrogen from the HRT and the amphetamines from your ADHD medication need to use those exact same taxis to be broken down and escorted out of the bloodstream.
So if you introduce HRT, suddenly a flood of estrogen jumps into all the available CYP2D6 taxis.
Yes, the estrogen occupies the enzymes, which means the amphetamines are left stranded on the curb, just circulating in your bloodstream much longer than they are supposed to.
Which slows down the clearance rate.
Exactly. Your standard, safe dose of ADHD medication might suddenly accumulate in your system, acting like a much higher dose and extending far past its normal active window.
Wait, so taking HRT can accidentally overdose you on your normal, everyday ADHD medication?
It can absolutely lead to an accumulation that causes overstimulation, insomnia, and cardiovascular stress, which is why the dosage of this stimulant often needs to be adjusted downwards once HRT is introduced.
That is just wow. And it doesn't stop at the liver.
Nope.
The kidneys are the other half of this filtration system. The data notes that the urinary recovery of amphetamine is highly dependent on the pH level of your urine.
Yes.
This was the most bizarre detail to me. Why does urine pH matter for a brain medication?
It all comes down to ionization. Amphetamines are what chemists call weak bases. When a drug passes through the kidneys, the body has to decide whether to flush it down the ureter into the bladder or reabsorb it back through the kidney walls into the bloodstream.
And pH makes that decision.
Yes. If your urine is highly acidic, the amphetamine molecules become ionized. They gain an electrical charge.
Okay.
The lipid membranes of your kidney walls repel that electrical charge, so the drug stays trapped in the urine and gets flushed out of the body quickly.
But the research states that if the urine is alkaline, meaning less acidic, with a higher pH, it reduces renal elimination.
Because in an alkaline environment, the amphetamine does not ionize. It remains neutral.
Oh, I see.
Yeah. Without that electrical charge to repel it, the drug molecule slips right back through the kidney's lipid membranes and re-enters your bloodstream.
Wow.
Your body just endlessly recycles the drug, prolonging your exposure to it. And since hormonal shifts and certain types of HRT formulations can subtly alter systemic pH and metabolic states, you are introducing a profound variable into a finely tuned system.
You are changing both the receptor sensitivity in the brain and the metabolic clearance rate in the liver and kidneys simultaneously.
Yes, it's a massive shift.
If the clearance rate slows down because the estrogen is taking all the CYP2D6 taxis and your kidneys are recycling the drug, you are looking at serious side effects like elevated blood pressure and an increased heart rate.
This is exactly why managing this transition cannot be done in a silo. A psychiatrist cannot just blindly up a stimulant dose without knowing what the gynecologist is prescribing for HRT, and vice versa.
And that brings us to the ultimate stakes of this conversation. Why is it so crucial for a listener to aggressively advocate for this cross-disciplinary care?
It's vital.
Because it goes far beyond just wanting to remember where you put your keys or staying focused in a meeting. It is fundamentally tied to broader physical health, specifically your heart.
The downstream consequences of untreated or poorly managed ADHD in midlife are severe. When executive function collapses, cardiovascular health is usually the first casualty.
The data outlines a massive study published in BMC Medicine. We're talking about health records from over 12 million adults across 7 different countries.
It is a staggering sample size.
Huge. They were looking at patients who had been prescribed antihypertensive medications, blood pressure lowering drugs. About 320,000 of those adults had ADHD, and the drop-off in taking their heart medication was terrifying.
It makes complete sense when you look at the pathology, though.
Yeah.
The core traits of ADHD: inattention, time blindness, working memory deficits, difficulty with routine, are the exact traits that make taking a daily preventative medication for a silent condition like high blood pressure incredibly difficult.
Right. Because you don't feel high blood pressure.
Exactly. If a condition doesn't provide immediate feedback, the ADHD brain really struggles to prioritize it.
And the study found that adults with ADHD are 45% more likely to have poor adherence to their blood pressure medications in just their first year of treatment.
45%.
Almost half just stop taking it properly. And that gap widens dramatically over time. By the 5-year mark, they were 64% more likely to have poor adherence compared to people without ADHD.
So if we pull back and look at the whole picture we've painted today, think about what is happening during perimenopause.
Okay.
Your natural estrogen drops. Because the volume dial is turned down, your ADHD medication's efficacy just vanishes.
Right.
Your resulting executive dysfunction skyrockets. You are overwhelmed, you are forgetful, and you are fatigued.
Yeah.
In that specific state, how likely are you to perfectly manage a daily regimen for a chronic midlife condition like hypertension?
You aren't. It falls completely off the radar. But there is a hopeful twist from that same 12 million person study.
There is.
When patients with ADHD were actively taking their ADHD medication, their adherence to their blood pressure treatment was substantially better. They were nearly 50% less likely to have poor adherence at the 5-year mark.
That is a massive risk reduction.
Yeah.
Yeah. It proves that treating the ADHD isn't just about mental clarity or workplace productivity. It is a prerequisite for physical health. Optimizing your HRT to ensure your central nervous system stimulant actually works isn't some luxury. It is a foundational pillar of your long-term cardiovascular health. If your ADHD is unmanaged because your hormones are out of balance, your physical heart is literally in jeopardy.
So bringing it all back to our original mission, does taking HRT profoundly alter the efficacy and clearance rates of CNS stimulants used to treat ADHD?
The clinical answer is a resounding, scientifically backed yes.
It alters efficacy by replenishing the estrogen your brain needs to synthesize and amplify dopamine, effectively restoring the power of your medication.
Yes.
And it alters clearance rates because that newly introduced estrogen competes for the liver enzymes responsible for metabolizing those exact stimulants.
And because of that dual impact on both the brain and the body, symptom severity and treatment responses are going to vary wildly from person to person.
There's really no standard one-size-fits-all playbook.
No, none. It requires a doctor monitoring your blood pressure, adjusting your stimulant dose to account for liver metabolism, and fine-tuning your HRT, like utilizing cyclical micronized progesterone to find your specific equilibrium.
The biggest takeaway for you listening right now is you aren't imagining things, and your brain isn't broken.
Definitely not.
You are just navigating a massive neurochemical shift. The foundation shifted, not you.
Which leaves us with a rather profound concept to consider.
What's that?
Well, if our baseline brain chemistry, how we focus, how we regulate our emotions, and even how our liver physically metabolizes drugs, is not actually a fixed trait, but rather a fluctuating tide entirely driven by our hormones, shouldn't all psychiatric prescribing and all medical dosing for women be fundamentally tied to their specific reproductive timeline?